So I'm Lydia, I'm one of the registrars in South Yorkshire. I'm currently working in Doncaster. So I'm going to talk about infective endocarditis. So main objectives are basically, I just want to try and let you know what you need to be aware of as SHOs and what kind of things you can do for these kind of patients, because you will come across at least one or two of them whilst you're working as an SHO. So we'll go through identifying the clinical manifestations and when you should suspect it. Make sure you're aware of the typical organisms that are identified in IE. What investigations you can be doing and what investigations to be thinking about doing. And also just make you more aware of some of the main complications and when you should escalate these patients. So what is it? So it's an infection involving the endocardial surface of the heart. It is rare, so when it's kind of quoted, recent US study quoted it around 15 cases per 100,000. Obviously that in itself might not mean very much to you, so to put it in more of a clinical context, I might probably see on average a handful of patients, maybe between sort of 1 and 5 patients per year whilst working in a DGH presenting with an endocarditis. So you will probably see it at least once whilst working as an SHO. And obviously you'll see it more often if you're working particularly in cardiology, or if you've even got a rotation in microbiology, and particularly if you're working in tertiary centres in those areas. It's often a disease of insidious onset. It has vague symptoms that often mimic a spectrum of lots of different infective disease. It involves multiple systems. Although it often presents quite insidiously, it can lead to quite rapid deterioration, and it's frequently quite fatal. So I've just put here some information from a recent study a couple of years ago that just highlights that the mortality for endocarditis is quite high, and the risk of complications and need for surgical intervention is also relatively high. So it's something to be worried about when you've got patients that have it, because it's not a very good disease. So when thinking about who gets it, so that usually depends on 3 general factors. So particularly looking at patients who have predisposing risk factors, opportunistic pathogens that might enter the bloodstream, and with any kind of infection, people that have affected host immune response, so particularly patients with diabetes, malignancy, they're always going to be more likely to get infection. And if they've particularly got those predisposing risk factors, they're going to be more at risk of getting endocarditis. So when we're thinking about endocarditis and those predisposing risk factors, we're thinking about patients who've had previous endocarditis, patients with prosthetic valves or other prosthetic material in particular, not forgetting patients who've got cardiac devices, so pacemakers, structural heart disease, so either degenerative heart disease or some kinds of congenital heart disease. And then obviously those patients who undergo and engage with risky behaviours, so thinking about your IVDUs, or more recently there's been a bit of a shift in the terminology that we use to describe some of these patients. So you might see PWIDs, or patients who inject drugs more commonly. Let's just be mindful, and that's what that is if you see it in notes. And then obviously things about patients who have poor dental hygiene, and patients who've had tattoos and piercings, particularly in places that haven't really been abiding to strict sterile protocols. So when should you suspect it? So as with most things, when you're diagnosing patients, you're using these key factors to try and help you piece together the story, to help you confirm your suspicions and formulate your diagnosis. So the medical history usually is actually very vague in endocarditis. So it might be somebody presenting with ongoing symptoms that have been for the last couple of weeks or sometimes even months, generally unwell. And then obviously you're looking at any clinical features that they might present with. And then if you're fortunate, you might have some information already available from either blood cultures that have been done previously or any other imaging that might have been done. So I sometimes find when thinking about clinical manifestations, it's helpful to break that down into your constitutional symptoms. So these are your more generalised, non-specific indicators of disease. Your systemic symptoms, so they can affect the entire body, but they also relate to more specific organ involvement. And then obviously your clinical signs, which are obviously going to give you more objective evidence of disease. So can anyone name any common symptoms or signs that somebody with infective endocarditis might describe or might present with that you might find on examination? Yeah, so Janeway lesions and Osler nodes. Do you know which one's which? So one of them's painful, one of them's not painful. Do you know which ones are? Yeah, so your Osler nodes are typically painful ones that are found on the tips of your digits, and the Janeway lesions are the more flatter, non-painful lesions found on the palms of the hands or sometimes even the soles of the feet. Yeah, so your constitutional symptoms are things like your fever, fatigue, night sweats, weight loss, anorexia, all those things that don't necessarily point towards infection. You might also be thinking about things like malignancy if those kind of things came up. Your systemic symptoms can sometimes point you in a bit more of a specific direction, but again, they're often very vague. They can sometimes give you a bit more information about thinking about possible embolic phenomena and where that might be in relation to. And then, yeah, your clinical signs. So your most important things are things like your new murmur, splinter hemorrhages, Janeway lesions, Osler nodes. We don't usually see these very often because a lot of patients now, thankfully, they present usually before they've developed these features, but you can see it, and we do still see it sometimes. It's just not as often as you might think. And then what might be more likely that people will present with isn't necessarily signs of the endocarditis as such in terms of the new murmur, but you might see them present with features suggestive of an embolic event, so neurological signs or abdo pain. And then you've also got features of chronic infection, so particularly given that these patients will have had infection ongoing for a couple of weeks, you usually see things like a low HB, low albumin, and usually a grumbling mid-range CRP. They don't often present with CRPs in the hundreds. It's usually kind of grumbling. A lot of these patients might have been given antibiotics in the community, and that might have sort of affected their CRP response. So when thinking about microbiology, infective endocarditis gives you a sustained bacteremia, and so that's why it's really important to be getting multiple blood cultures, because you want evidence of that sustained bacteremia. So ideally, we want 3 sets of blood cultures. That's still relevant even if patients are afebrile, because a lot of the time you see people write in the notes that they won't do cultures unless patients spike a temp, but with a sustained bacteremia, you're going to get evidence of that regardless of whether or not we've got a temperature. Most guidelines stipulate 6 hours apart. The Duke criteria does say you can get 2 at 12 hours. And sometimes in severely septic patients, you can get a minimum of 2 cultures in the first hour, but most of these patients don't really present profoundly septic. If they're going to present acutely, it's usually because they've either developed acute pulmonary edema or because they've had a massive embolic event, but most of the time you have time to get those cultures. So if we're thinking about the common organisms that are found, does anyone know? There's generally 3 typical organisms that we see in patients with endocarditis. Does anyone want to have a guess at what they think they are? Yep, strep viridans, somebody's mentioned there. There's 2 more. Yeah, Staph aureus, yeah. So yeah, so the 3rd one is Enterococcus. So your Staphylococcus, generally Staph aureus, your strep and Enterococcus, typically Enterococcus faecalis. They're your 3 most common organisms that you'll find in patients presenting with endocarditis. The caveat of those 3 blood cultures is that you only need 1 positive culture with a typical organism to raise your suspicion of somebody having possible endocarditis. Obviously, if there's other things in the history that are pointing towards you thinking that they might have endocarditis, if they've got a Staph aureus bacteremia and they've got a raging cellulitis, then obviously that's more likely. But it's just to have that suspicion in your mind. It's probably worth mentioning about coagulase negative staph. So You might often see this on blood cultures, particularly with a sort of additional comment from the microbiology team saying possible contaminant, because coagulase negative staph is often one of those things that comes up as a possible contaminant. But it's worth bearing in mind that the only time you shouldn't really discredit a coagulase negative staph is in patients who've got prosthetic material. It's an organism that quite likes prosthetic material. So someone who's got a prosthetic valve or even a pacemaker, if they've got coagulase negative staph, then take it seriously. And then you've also got your more elusive organisms. So things like your typical hack-egg organisms. And some of these can be a bit more difficult to identify in your conventional culture. So particularly when you're thinking of patients who might have what we call a culture negative endocarditis. In those situations, you have to think about other techniques to try and grow an organism. So things like serology, PCR, and sometimes immunological techniques. Sorry about that. So moving on to imaging. Imaging always plays a really important role in diagnosing infective endocarditis, not just in terms of diagnosing it, but also in terms of assessing the complications and planning for any intervention that might be needed, in particular things like surgery. So transthoracic echo is always the first line imaging modality that we use. And what you might see on that is clear evidence of a vegetation, an abscess, new valvular regurgitation. And it's always important to compare to previous imaging because people might have what might look like an endocarditis, might look like a vegetation on an echo, but sometimes you see that there are small structures that people might have had on previous echoes all their life. So if people have previous echoes, it's always good to try and compare. It's worth mentioning that transthoracic echo is not always the best modality for viewing vegetations, but especially if they're small, so if they're less than 2 millimeters, and especially if they're right-sided. So you don't always get good views of the right side of the heart, particularly your pulmonary valve. You don't always get a good view of that on all patients. So don't be surprised if you request an echo and you get hit with the typical phrase of infective endocarditis cannot be ruled out by TT alone. And so therefore, in those situations, that's when you need to be thinking about whether or not these patients might benefit from a TOE. And that's usually if you have ongoing strong clinical suspicion of them having endocarditis, or perhaps if you've confirmed that they've maybe got a small vegetation on a valve, you might want to then refer them for a TOE to get a better assessment of the valve, and if they've got any regurgitation, to get a better assessment of that. And usually if patients are going to be referred on for further intervention like surgery, the surgeons will usually want these patients to have TOE just to get a few more pictures to help them plan. And then we often use imaging for ongoing monitoring. So sometimes patients who are responding to antibiotic therapy, they might have maybe weekly echocardiograms for monitoring to make sure that any valve disease is not significantly getting worse, and to monitor the overall general size of the vegetation. And then other imaging that we might think about in endocarditis relates to looking for indirect evidence, and particularly thinking about those embolic events from left or right-sided lesions. So your adjunct imaging, so particularly things like CTs, to look for embolic events either in the brain or within the abdomen. CTPA to look for evidence of septic emboli to the lungs, or to further assess areas of multifocal consolidation. Sometimes we think about angiograms for patients that might have a suspicion of mycotic aneurysms. And then there's also sometimes a place for PET-CT, usually in patients with prosthetic endocarditis, so things like pacemakers or prosthetic valves. PET-CT can be quite useful, but obviously the availability of that isn't always, it doesn't always make it possible to get it quickly. And then I suppose the main thing for you is that what you want to do is you want to try and look for that indirect evidence with evidence of embolic phenomena. So imaging of the brain, abdomen, lungs, vessels, and particularly with importance to thinking about the spine. So patients who have spinal infection usually have coexisting infection somewhere else. And endocarditis is quite high up on that. So I only recently found out kind of some statistics, but essentially around patients who have endocarditis, around 10% of those might then have a coexisting discitis or spinal infection. But of patients who have a confirmed spinal infection, around 20% of those patients will have a coexisting endocarditis. So it's therefore reasonable, if you're presented with a patient with back pain and infection and you've confirmed a discitis, to have that strong clinical suspicion that perhaps there might be something else going on, and why have they developed a discitis, and where is that infection actually being seeded from, because it's likely that it might be from an endocarditis. This is just an example of what you might see on imaging. So the first image shows quite a large vegetation on the mitral valve, and then the second image shows this is an aortic root abscess that's developing here adjacent to the aortic valve. It's worth giving a nod to the Duke criteria. It is still used. I use it sometimes, not mainly as a sort of guide. I think it's quite useful to help as a prompt, particularly when you're trying to think about what kind of tests you want to do and thinking about other complications. It's worth bearing in mind that the Duke criteria was developed for quite large cohorts. So like with most scoring systems, it doesn't always apply very well to individual patients, but it's quite useful and handy to have as a prompt to help guide you when you're making referrals and things. So thinking about treatment options, so most of these patients will need long-term antibiotic therapy, and with that they'll often need long-term lines. So it's worthwhile for you guys thinking about referring these patients for PICC lines and midlines early on, especially when a lot of these patients, particularly patients who use IV drugs, can be quite difficult to bleed. So it's worth thinking about referring them on for PICC lines and midlines early on to save yourself a bit of a headache and not be called in the middle of the night when you're on call to have to re-cannulate somebody. Patients with prosthetic valve endocarditis often require longer than the usual 6 weeks of treatment. And that's partly because of the mechanical material, antibiotics don't penetrate as well, and also because they're often more susceptible to less common organisms that generally are harder to treat anyway. Antibiotic therapy is usually based on your first day of effective antibiotic therapy, and that's related to your latest organisms that you've got in culture. So that's why microbiology will often, when you ring them, ask what day were they started on X, Y, and Z antibiotic, because a lot of these patients end up being put on multiple different regimes of antibiotics before they've even had a culture that's possibly identified something. Gentamicin is often used in Staph aureus, but now more commonly we do use flucloxacillin. Aminoglycosides are still used, but you just have to bear in mind that they'll need regular monitoring of their renal function whilst they're having that. Rifampicin is usually added for prosthetic valves. And prosthetic valve endocarditis is usually quite difficult to treat, as I said, with antibiotics. So these patients will pretty much always need early consideration of surgical intervention. And for you guys, it's important, I guess, to be aware that anyone who's got an infected pacemaker, the device always needs to come out. So that always needs to be referred early on. And then with regards to ECG monitoring, we mainly do this for patients, particularly with aortic valve endocarditis. And that's to look for evidence of them developing an emerging abscess. So in particular, a widening of the PR interval has been found to be sensitive for abscess formation. So in clinical practice, if we're doing that on the ward, we might request for somebody to have an ECG maybe once to twice weekly, just to review things whilst they're stable. So when thinking about prognosis, a lot of these are quite self-explanatory, but we know that IE comes with high rates of mortality, and there are some specific predictors of a poor outcome. There's a few that are kind of worth highlighting. So Staph aureus bacteremia is generally quite destructive and aggressive, and those patients generally don't do very well, particularly if it's picked up quite late. And then there's other, obviously, organisms that are just more difficult to treat. ultimately, I guess the take-home message from this slide is that if you've got a patient who has any signs of complications from IE, or who just you don't think is really responding very well in terms of their inflammatory markers, and clinically you need to be referring them early on for assessment and for intervention. So thinking about referring on for intervention, surgery is usually required in around 50% of patients with endocarditis. There's generally 3 main indications. So you've got your heart failure, uncontrolled infection, and then it usually comments on prevention of significant embolic events, but obviously, usually what happens is a lot of these patients have an embolic event, and then that's usually enough to then think about referring them on for surgery to prevent them having another one. So it might be somebody maybe has a small stroke, and then you refer them because you want to make sure they don't have a massive stroke. And obviously, ideally, this should be done in a timely manner, because the longer you wait, the more chance there is of them having a big embolic event, or the more chance there is of them having more degenerative valve disease. But obviously, it's difficult to try and get some of these patients across for surgical intervention, particularly if you're referring from a district general. So I guess the main aim of surgery is to avoid irreversible structural damage, to prevent progressive TCF, and to try and prevent systemic embolic complications. But yeah, the main thing is just thinking about making sure you've got that in the back of your mind so that you're referring early, so the patients aren't having to wait too long. And that's why it's really important to be aware of the endocarditis team. So that you might have a small endocarditis team based locally. If you're working in a DGH, it might be that it's one consultant and one microbiologist who would just have a keen interest in it. But they're generally based in tertiary centres. And patients with complicated infective endocarditis should be managed early in an IE centre with an dedicated endocarditis team. And that essentially means that they have access to immediate surgical facilities. So for Yorkshire, you're thinking about LGI and the Northern General in Sheffield. It is essentially an MDT-led management process. So it involves cardiologists, microbiologists, surgeons, and sometimes even specialists from other areas. So if you've got a patient who's had a stroke, then you might get the neurologist involved. Patients with mycotic aneurysm, you might be getting vascular involved, sometimes neurosurgery. So it does involve a lot of people. And they usually, most centres will do kind of weekly MDTs where they'll go through a series of cases that have been referred. So when thinking about prevention, I'm going to throw this out to the group as a question. Who thinks that patients with high risk of endocarditis should get routine prophylaxis for procedures? I don't know if people can just put yes or no if they think. Not usually. Yeah. So the answer to that is it depends where you are in the UK. So it's still quite controversial. There's generally 2 kind of schools of thought about it. So NICE have now stepped away from recommending routine antibiotic prophylaxis, but the European and Scottish guidelines still have it included for high-risk patients undergoing high-risk dental procedures, but they don't usually include it for patients undergoing other procedures like endoscopy. The general school of thought is that on one side, people think that if you have risk factors for endocarditis, if you then went on to get endocarditis, that would be very bad. And so therefore, why would you not give them prophylaxis? But the other school of thought is that if you have a significant dental infection, then general things like brushing your teeth is probably just as likely to cause seeding of infection. So you wouldn't give antibiotics for general brushing. So why would you give it for everything else? But they're generally the kind of 2 schools of thought. What's probably more important is trying to reduce their risk in other areas. So it's important to make sure that these patients have regular dental reviews and maintain good dental hygiene, which obviously isn't easy. I know we probably all know how hard it is to get a dentist appointment, but it's worth making them aware of that, and particularly patients who've had previous endocarditis, they really should be sort of boosted up in terms of priority with getting dental reviews. Making sure that patients who are involved in certain risk behaviours, so things like tattoos and piercings, that they're aware that, you know, they should be going to places that are clean and that are having strict sterile protocols. And then obviously what is sometimes overlooked is those patients who are injecting drugs, and we should really be looking at trying to get them engaged in relevant support services, both whilst they're in hospital, and then hopefully trying to set up some systems so that they can get ongoing support in the community. Because it's usually these people that are your reattenders and your patients who end up having recurrent infective endocarditis. And generally, when these kind of patients get recurrent endocarditis, they usually don't do very well. So it was kind of a quick whistle-stop tour of endocarditis. I guess the main take-home messages that I think are probably important for you guys as SHOs are that you should try and prioritise cultures. That's probably one of the most helpful things that you can do. You can obviously request transthoracic echoes, but just with any test that you're requesting, particularly any kind of form of imaging, it's really helpful to put a question in. Obviously, you know the kind of main organisms, but it's also worth just bearing in mind and having that high level of suspicion, especially with regards to possible embolic events. And then probably another more important thing is that you should try and seek early involvement of cardiology and micro teams when you're suspecting it, or even when you've definitely had confirmation of it on an echo. And you shouldn't be afraid to sort of ask questions, because obviously it is a serious condition and it comes with a very high rate of mortality. So you need to escalate, you need to ask questions, you need to push if you're not happy that you've got a patient who you think might have it and they need more investigations doing. So don't be afraid to do that. These are some of my references. Thanks for listening. I hope you found it useful. If anyone's got any questions, I'm happy for them to ask. I didn't put my email on here because apparently it's going on YouTube, but if anyone wants my email to ask any questions, I'm happy for Joseph to give it out separately at the end.